The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. It's December, and so we get to celebrate Christmas, and it turns out 3 years ago we had Tim Bahr on the podcast, and he's such a delightful guest that we're so happy to have him back today. Welcome back, Tim.
Thanks for having me, Paul. This is great.
So if we're talking to Tim Bahr, we're talking about a topic related to newborns and blood. Is that safe?
Yep. That's what we do.
I know, I've been curious, were you interested in that topic before you started your fellowship, or is that something you developed an interest in once you got here?
Developed an interest, and I'll say this, and I think other people have this interest. If you want to learn to do research well and be successful at it, sometimes who you pick is more important than what you pick early in your career. And so I came to the University of Utah to study neonatal hematology for a research emphasis with Dr. Bob Christensen, and then subsequently Dr. Robin Oles joined us too, who was also trained by Bob. And then I fell in love and have never fallen out of love with it.
Bob, who's been on the podcast before, is just a giant in the field, isn't he?
Yeah, yep. He was early in hematology with Maxwell Wintrobe at the University of Utah when he was on faculty there and really developed the field of hematology. And then Bob said, I want to be a neonatologist, and babies have very unique pathologies and physiologies related to blood. So, yep, Bob has done a remarkable contribution, and we still work together most days of the week.
Please tell him hello. He's a delightful person. And probably much to his and Robin's chagrin, I somehow found my way onto a paper with the two of them once when I was a resident, because they make things happen.
Yep, they're great. And that's, I think you highlight something that's important in medicine. You're great at this too, Paul. We need to be generous to the next generation, and they have been extremely generous to me.
Well, and you're doing such a great job. So before we start, you want to mention your disclosures?
Yes. So today we're going to be talking about hemolytic disease of the fetus and newborn. And there's an exciting phase 3 trial funded by Johnson & Johnson for a drug called nipocalimab is the generic name. And I am a sub-investigator for the Intermountain Health site for that drug. So I do not receive any extra compensation than my salary, but they do help fund our research program.
And we're likely to mention at least its possibilities in a couple of weeks.
Yep, absolutely.
Good. I asked you beforehand if you'd be willing to do this, but last time we talked, we were talking about the new bilirubin guidelines. You want to give us in just a couple of sentences what the results have been of the 2022 guidelines for bilirubin treatment?
Yeah, there's probably some experts listening that are even better at this than I am, summarizing some of the changes that I made. And those experts are called general pediatricians. I don't get to work as often in the newborn nursery, but what I understand based on the Intermountain data and folks like Peter Lindgren, who is at Intermountain Health and oversees a lot of that work.
Former guest of the podcast.
Awesome. Is that our treatment rates used to be somewhere probably between 8 and 10%. So 8 to 10% of term newborns used to receive phototherapy. And what I understand is that in the state of Utah, probably more Intermountain Health per se, that our rates have dropped to about maybe 1 to 2% being treated. And as far as we can tell, we are treating fewer babies without harm. And so perhaps, I think not just perhaps, we'd say out of an abundance of caution, because we didn't have better information, we were over-treating before, which is okay, but our job is to improve, and it seems like that is happening.
Yeah, that's great. Well, let's dive right into today's topic. We want to talk about alloimmunization today. The occasion for this is partly new guidelines, but it's also, I think, a topic that's not that easy to understand sometimes. And so I think it's a good one for us to talk about. So let's just set the stage. I should also mention in passing that one of the sources that I use to do groundwork for the outlines that I work on is up to date. And I see that the co-author of the article about infant alloimmunization is a Timothy M. Bahr. Any relation of yours?
It is. I must disclose, it's in desperate need of updating, Paul. And so I've contacted the editor. So, yes, that's me, but there is better information coming out and take it with a grain of salt and look for updates as you continue to use
Sure.
up to date. Yep, but that is
Sure.
me. Yep.
Sure. Okay. So what is alloimmunization?
Yeah, alloimmunization is a process when the human body creates antibodies against foreign antigens. And when we use this term, generally we're actually, and today we're specifically talking about red blood cell alloimmunization or alloimmunization against red blood cell antigens. And so this occurs when humans are exposed to foreign red blood cell antigens that they do not have on their own red blood cells.
So how does a parent develop antibodies against their own child?
The two most common ways to become alloimmunized and start making antibodies against red blood cell antigens is by transfusion or by pregnancy. Would it be okay if I give you an example?
Of course.
Okay, so I think it's best to use an example because this brings some familiarity to people to explain this. So let's use my wife as an example. Her name's Haley, and let's imagine she's type O negative blood type, and I am actually truly O positive. And that means Haley's red blood cells do not have the A antigen and the B antigen. That's why she's type O. And she also would lack the Rh antigen, that's the negative. And more specifically, that's actually called the Rhd antigen on her red blood cells. So every time that, for example, an O negative mom and an O positive dad or parents have a baby together, there is at least a 50% chance that the fetus will have O positive blood. And then during the pregnancy, in all pregnancy, there's some amount of fetal blood that enters the mother's circulation and can cause her body to start making Rhd antibodies and thus become alloimmunized against those Rhd antigens that the fetus inherited from the father. In the case of Rhd antigen, which is common, we prevent this by using RhoGAM or RHIG, but the Rhd antigen is the only one of hundreds of antigens that we may or may not have on our red blood cells that we actually do prophylaxis against. In addition, sometimes there are other ways to be exposed to the Rhd antigen by transfusion. If you're in trauma, sometimes they have to give O positive blood to an O negative person because that's all we have on the shelf. And sometimes we have misses and known misses and unknown misses. An unknown miss, if you conceive a baby and have a spontaneous abortion or spontaneous termination early in the pregnancy, even before you know you're pregnant or you don't go to the doctor, you may be exposed to blood from the fetus without even going to a hospital to deliver, and that's another way you can become alloimmunized. So one last thing on that note, other antigens that are more commonly result in alloimmunization and the disease that we're going to talk about, which is HDFN, include things you probably heard, pediatricians may have heard about, like Kell, big C, big E, Duffy. Those are the most common ones besides the D antigen that result in alloimmunization and cause this disease we're talking about called hemolytic disease of the fetus and newborn.
And does exposure and development of antibodies for all of those also require exposure to either a fetus or other blood?
Yes. Yep. You have to be exposed to a foreign antigen that you lack on your red blood cells to start developing antibodies against it. And it has to be a sufficient amount. Yep.
Okay. So how do antibodies get into the fetus's circulation?
Yeah, so that's one of the great miracles of pregnancy. And that's where we get our immune system, our passive immunity to when we're babies, is that antibodies cross the placenta, specifically IgG is the one that crosses the placenta. And so the mother's humoral immunity, which is our antibodies, IgG can cross the placenta into the fetal circulation. Then when you're born, you have these great antibodies that can continue to protect you. If you're breastfed, then you continue to get IgA from the breast milk, and that provides immunity for the newborn. That said, antibodies that we don't want to cross can also cross. And so, how do antibodies get into the fetal circulation? It's these alloantibodies, which are undesirable, cross just like the antibodies that we do want to cross the placenta.
I'm guessing there's a hierarchy of which antibodies are most concerning.
Uh-huh. You know, it's interesting. The genetics are a little complicated. I'd say outside the scope of this talk and perhaps outside the scope of Tim Bahr's teaching ability. But the ones that tend to cause alloimmunization most frequently also tend to be the ones that are most severe with some variation and exception. So the ones that cause the most significant damage are D. And that's why ROGAM was such an important development, or I should call it RHIG, is because you can imagine that it's pretty common in our population. About 15% of the time is an often quoted statistic that an O positive mother will have a baby with an O negative father. And that creates that possibility of the blood to cross. Before ROGAM, we weren't able to prophylax against it. So I'd say number one is generally RHD, the D antigen. KEL, obstetricians are taught that KEL kills. I don't mean to be, you know, unkind or
Not at
treat it
all. Yeah.
treat it,
Yeah.
jokingly, because this is not a joke, but the KEL antigen and antibody can cause a lot of issues. The other ones we talk about, so D, and then within the RH group, there's big C, little c. So we're very specific about whether it's capitalized or not because they're different. There's big E, little e, and those are common and those are often can cause damage. And then I'd say Kell and Duffy are the other ones. If you want, I'll give you a little bit shorter list. We always remember that, D, Kell, and little c, we tend to be pretty scared of, but those other ones I listed can also cause some significant hemolysis.
Is that why there's not a ROGAM equivalent for the other antigens?
That's a good question. I actually don't know if people have pursued that. I'm sure we've talked about it and thought about it. The reason why, yes, I think you're probably right, Paul. If I had to guess, I can't say for sure. One is the frequency of occurrence. So the frequency of alloimmunization is probably much less. And I know that for certain that especially pre-ROGAM, alloimmunization to D was very common, but these other ones are not as common. And then severity. Is it worth it to give this drug or, to give the passive ROGAM antibody to prophylax against it? And I guess we haven't quite reached that threshold where the benefit outweighs the cost.
Gotcha. So what's happening at the cellular level with alloimmunization?
At the cellular level.
Mm-hmm.
Yeah, so great question. So alloimmunization is not necessarily a problem. You can walk around your whole life alloimmunized. As far as we know, there's no issue with it. But when, at the cellular level, when those antibodies cross the placenta into the fetal circulation, if the fetus has the antigen to which the mother is alloimmunized, it causes hemolysis, which is accelerated red blood cell destruction. And it results in two things that are pretty clinically significant. One is hyperbilirubinemia in the newborn, and then anemia. And the good news is, if you can get through a period, it is always time limited. But those are the two things that are happening. And cellularly, it's a little bit complicated, the physiology, but just like a lot of things in immunology, those antibodies actually attach to certain receptors and to the antigens on the red blood cell, and then they are either destroyed or they undergo early senescence through part of the immune system of the body.
So what's Hydrops fetalis? Can you explain that to us? It's a term we use a lot, but explain what's going on there.
Yeah. When we're taught in medical school and in especially our pediatrics residencies, we're taught that Hydrops fetalis comes in two varieties, immune and non-immune. And that's sort of a historical distinction because the most common cause historically of Hydrops fetalis was alloimmunization of the mother and hemolytic disease of the fetus and newborn, hemolytic disease of the fetus. And
Mm-hmm.
so Hydrops fetalis, the definition of Hydrops fetalis is an accumulation of fluid in at least two body compartments. And to tell you the truth, as far as I understand Hydrops fetalis, it basically tells you, well, it's an indication in this case that the baby's suffering from severe anemia and that the compensation mechanisms are starting to fail in the body and that the fetus is starting to die. And so hydrops fetalis is the presentation of untreated severe fetal anemia, and in this case, severe hemolytic disease of the fetus resulting in anemia.
So acting differently from the non-immune hydrops that's usually caused by like a heart lesion or something, right?
Right. Yep. Genetic heart lesions, stuff like that.
And overtaxing the system trying to keep up with the needs of not being able to supply with severe anemia.
Yep. Yep.
Gotcha. Okay. I suppose it's also important for us to also remind ourselves that sometimes this is a severe, fast, overwhelming reaction, but there are also more indolent reactions that happen that we should also keep in the back of our minds.
Yeah. And Paul, are you talking about ABO perhaps?
Yeah. Uh-huh.
Okay. Yeah. So one thing that's very important to delineate or to understand is I think in our pediatrics residencies, we're often taught about ABO, and we use this term ABO incompatibility. The most common case would be a type O mom and a baby that's type A, B, or AB. And that can also cause a process just like this. So what's the difference? Well, anti-A and anti-B antibodies are naturally occurring. So every type O person like myself, by the time you're about 6 months of age, starts to develop anti-A and anti-B antibodies, not due to exposure to the A and B antigens. We think that's due to microbial exposure.
Oh, interesting.
Yep.
Yeah.
So can ABO cause hemolytic disease of the fetus and newborn? It can, but for some reason it tends to be mild. And I would say we probably have blamed ABO more often than we should for severe hyperbilirubinemia. At least that's what we hypothesize in some of the data that we have. Now, on occasion, I take care of a baby where I do think that their severe hyperbilirubinemia is actually due to anti-A or anti-B disease. Sometimes I will actually test the mother for anti-A and anti-B titers. If she's type O, baby's type A, B has a positive DAT. I'll actually ask the lab to quantify the amount of anti-A or anti-B. That's not a standard test. And to prove it to myself or to the parents and to make
Mhm.
sure that we have found the cause. And yes, if for some reason a mother has a very high anti-A or anti-B titer, that can absolutely result in pretty severe disease. But I would say that is not common. It does happen, but I would say it's less common than the alloimmunization we are talking about today. And when I work with groups and do research in quote alloimmunization and quote HDFN, generally we are talking about antigens and antibodies other than A and B.
And so is the theory then that, and I think I'm just sort of synthesizing what you said, other antibodies then?
Yep.
Right. All right.
Yep.
I think that I'm just sort of asking this again to reinforce it in my mind. So, what's the importance of being proactive and decisive in the presence of hemolytic disease?
Yeah, it's because this type of hemolytic disease puts babies at HDFN puts babies at increased risk for the sequelae and the morbidity and even the mortality of the fetus and the newborn, puts them at increased risk of all sorts of things. So let me rephrase that. I'll just sort of say that over again. Why do we need to be proactive about this? Well, the first reason we need to be proactive is actually in pregnancy. The standard of care in obstetrics is to follow moms who are alloimmunized closely because their fetus is at risk for fetal anemia and possibly hydrops and death. And so they are followed closely. We may have a chance to get into those details in the podcast, but
Mhm.
I talk your ear off about that. Even though I'm not an obstetrician, I try to do my best. In the newborn world, as newborn providers, we have to be proactive about it because those babies are the babies that are at some of the highest risk for the sequelae of hyperbilirubinemia and then subsequently anemia. And so, unfortunately, the most recent case I have seen of kernicterus spectrum disorder was due to alloimmunization, and it was because it was missed. Baby showed up in the emergency room at day 5, and it had been missed. These are the kids. We have protocols in place, and if we get into the guidelines, I can talk about that. We have protocols in place to not wait until the standard pre-discharge bilirubin. We check it at birth from the cord. And we need to be aware that these babies are coming because sometimes when the disease is severe, if you check the first bilirubin at 6 hours, you might be behind and you might be already headed towards an exchange transfusion. Whereas if we treat these babies early and monitor them closely, especially in the cases of severe disease, in most cases we can avoid exchange transfusion and really kernicterus.
Yeah. And we'll talk more about that next week as well. So, very frequently, because of good obstetric care, we know that baby's at risk for alloimmunization because of testing or pregnancy. But sometimes a baby may present as a mystery. When should a provider suspect hemolytic disease rather than physiologic jaundice?
Yeah, well, as pediatric providers, one of our responsibilities is to check the maternal labs. And as far as I know, it is the standard in every hospital in the United States of America that if a mom presents to labor and delivery and does not have an antibody screen, which is the test to detect alloimmunization, they will conduct it. upon admission, or if she delivers precipitously as soon as possible. As a pediatrician and a pediatric provider, just like if I can't find an HIV status on the mom or a hepatitis B status when I take care of a baby, if I can't find an antibody screen for the mom, I will call up labor and delivery and say, hey, where's the antibody screen? We don't have one. Please run one.
Yeah, yeah.
And so the reason why that is a universal test for all pregnancies is so that we can make sure we're protecting that fetus and that newborn from this disease.
Perfect. So let me just summarize if I understand it. So alloimmunization can lead to devastating results, but those are preventable with early recognition and aggressive treatment, potentially.
Absolutely. Yep. Both in the prenatal and the postnatal stages or phases.
Perfect. Very helpful. It sorted out a lot for me, Tim. So we'll talk next week more about evaluation and diagnosis. But thank you very much for the clarity. I appreciate that.
You're welcome. Thanks, Paul.
All right. And there may be people who have questions. Please send your questions to questions@vcurb.com. I'm sure there will be some. And Tim will talk again next week.
Thanks, Paul.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.